It's a pleasure to welcome you once again on the dais. You need no introduction to this audience. Yesterday you showed us the Achilles heel, and today you are showing us the solution. We welcome you to start your discourse.
Thank you very much, and good morning. It's always a pleasure to be here, and I think you will be a little bit disappointed that this is not the solution to the Achilles heel. So I have no disclosures. Briefly, what I'm going to talk about is discuss the types of dialysis vascular access, define what's a last option or exhausted vascular access situation, describe a HeRO device and its clinical utility, and discuss the clinical experience that has been reported in literature. This is not my clinical experience. The clinical experience reported in literature is, again, relatively very small. So, as we all know, the three common types of vascular access, arteriovenous fistula, arteriovenous graft, and tunneled central venous catheter, these are and have been the standard vascular accesses for a pretty long time, and there hasn't been much innovations as far as creating a new access. There has been tremendous improvement in the technology as far as the dialysis equipment is concerned, the monitoring and safety measures. But when it comes to vascular access, we still depend on AV fistula that was first created in the late 60s. Hybrid access, or the HeRO device, which is the hemodialysis reliable outflow device, that is something that has come on the scene in more recent years, in the last 5 to 8 years, and that is what I'm going to discuss about. But before I move into that, a brief review of locations of AV access. We have the upper extremity access and the lower extremity access. The principle always should be distal first, proximal later. Preferably AV fistulas, if possible, before you move on to an AV graft. A distal could be in the wrist, forearm, or proximal forearm, and then proximally in the upper arm, and then lower extremity could be a thigh axis. And the axis that we start off with are the conventional arteriovenous fistula, and if the conventional arteriovenous fistula are unable to be created, then we move on to a transposed arteriovenous fistulas. And the differences between these two, the conventional arteriovenous fistula, it's generally a one-stage surgery. It can be either in the forearm or in the upper arm, and surgically they are less challenging, and those are the AV fistulae that most nephrologists start off learning when they start creating their own AV fistulae. As opposed to that, the transposed AV fistula could be a one-stage surgery or a two-stage surgery. It can be both in the forearm and upper arm, and they are surgically more challenging and take greater time for healing. So once most of the routine access sites have been used up, generally we talk about running out of options, and that's when we start looking at alternatives. Now here, the question that should come to your mind is, have you really exhausted all options? And that's the critical question that you need to ask yourself and ask your team and ask your surgeons. And many a times what happens is the message is passed along, either the patient is not being followed by you, but patient comes in with some poorly documented medical history that there are no more accesses, the patient is dependent on a catheter. Or if you really take efforts to get some medical history, you might be able to find sites, and if you have a good innovative surgeon, skillful surgeon, you might be able to create an access, a transposed fistula, or get a graft in that will work much better than having a long-term dialysis catheter. But in the event, after you have evaluated, after you have done all the necessary tests, which I would suggest getting done at least a CT venography and looking at all the arterial segments to see if there are any potential sites that can be used to create a permanent AV access. And if the answer is no, then one should probably accept the fact that maybe there is no other potential for a routine or a conventional or a transposed AV axis. And in those situations, what we have to think about is an exotic AV axis. That's what I call it, an exotic AV axis. And here's a little algorithm that I generally follow, and we discuss it with our surgical team members. Last axis option, it could be a catheter-based axis or it could be a non-catheter-based axis, and that will depend on what you find on the investigations that you carry forward. So a catheter-based axis is possible if there is central vein stenosis, but it's not totally occluded. So if there is some open central vein, then you can exploit that central vein to create an axis. If there is a total occlusion of the central veins, then you really have to look into innovative axis such as the transhepatic or transrenal, that's completely an option when the central veins are totally occluded. There are catheters that are placed straight into the right atrial appendage. Again, those are really end stage axis situations. If the central vein stenosis, or if there is central vein stenosis with some way in some way where you can get a guide wire across the central vein stenosis, then in that situation, getting a HeRO device could be an option. Again, could be an option. Non-catheter based axis options should always be exploited first, and those are again innovative axis surgeries where you have axillary artery to opposite axillary vein, axillary artery to femoral vein or iliac vein, axillary artery to IVC. I mean, those are again much better accesses compared to using a HeRO device. So coming to the crux of my talk, HeRO device. So what exactly is HeRO device? So HeRO device, it's a hybrid device that has a graft component, which is your standard 6 mm PTFE graft. There is a titanium connector to which is connected a catheter segment, which is like our regular tunneled catheter, and the catheter, then the other end of the catheter sits freely into the right atrium. So essentially you have a PTFE graft that is tunneled into the arm, connected by a titanium connector, and a catheter segment that is left into the right atrium. And during dialysis, it's the graft segment that is cannulated like a regular PTFE graft. So what are the clinical criteria that we know and that have been used in some of the reported studies where a hybrid graft catheter device has been used? So exhausted conventional access sites in upper extremity, exhausted access sites in the lower extremity. So that is an absolute must. So you can get to that conclusion only if you have done a thorough investigation and a complete analysis of the veins and the arteries to come to that conclusion. Endovascular access to central veins it needs to be available. So if there is total occlusion, then there is no way in which you can place a HeRO device. The brachial artery lumen should be at least 3 mm wide. You are attaching a 6 mm PTFE graft to the brachial artery, which will work as an inflow. So if the brachial artery is small, then you cannot put a HeRO device. The heart has to be good. So any axis is essentially a circuit that starts at the heart and ends at the heart. So if your ejection fraction is very low, then your incidence of thrombosis within this device will be very high. And there shouldn't be any active infection, and the minimum systolic blood pressure should be at least more than 100 millimeters of mercury. So the first published report was in 2009 with experience from 36 patients. And in these patients, the incidence of bacteremia was very low, very similar to what we generally see with AV grafts. And the primary patency was low, 39%, and these patients, these accesses require frequent interventions to keep them patent, and the secondary patency in the first report was about 72%. Since then, there have been two relatively larger studies. The first one in 2012 with 164 patients, then the second one in 2013 with 60 patients, with a follow-up around 24 months. And again, as you can see, the number of interventions are fairly high, very similar to what you would expect in a graft So 1.5 procedures per patient per year, roughly 2 procedures per patient per year. 6-month patency is reasonable with multiple interventions, and the infection rates are relatively low as you would see with an AV graft, much lower than what you normally would see with a central venous catheter. And since then, there have been 8 studies published, and there was a review article that looked at all of these 8 studies. 6 were retrospective, 2 were prospective studies, and a total of 409 cases. And as you can see, the primary patency is 22% at 1 year, and 1 year secondary patency is about 60%. Bacteremia rate is low, but the incidence of Steele syndrome is fairly high. It can be anywhere from 1.4 to 22%, at least in this total of 400 cases. And again, that's why you have to be very sure about assessing the distal perfusion, making sure that the distal circulation is well maintained to connect a 6mm graft in the upper extremity. And again, as you can see, an ongoing theme that the number of interventions required are fairly high. There was one study that looked at using the HeRO device in obese patients, where there generally is a problem getting an AV fistula going, or even if a graft is placed, the graft may be difficult to keep it superficial, and cannulations may be a problem. And in these patients, the thought process was, can we use HeRO device as a primary access in these patients? And clearly, obesity was a much higher risk. The 1 year patency was only 10% compared to in non-obese patients, where one year patency is about 53% in this study group. So again, HeRO device as a primary access in patients who were obese is really not the right access that one should pursue. Another thought that has been looked into is, should one consider a HeRO device before considering a thigh graft or a femoral AV graft? And this was a retrospective study that compared 35 femoral AV grafts to 21 HeRO catheters. And as you can see, the primary patency rate and the secondary patency rate was statistically not significant between the two groups. So femoral AV grafts and the HeRO device both had fairly identical patency rates, fairly identical infectious complications. They were not statistically significant. And on the other hand, there was a much higher incidence of thrombosis with the HeRO device. A word of caution with the thrombosis in HeRO device, since this is a really long conduit, artificial conduit, the thrombus load or the clot burden is very high. So attempting thrombectomy in these patients can definitely lead to a higher incidence, and there have been case reports of large, massive pulmonary thromboembolism during an attempt to declot these devices. And finally, whenever we move into new devices, we have to look into the economics from as far as morbidity to the patient, and economics as far as costs to the society and to the patient. Managing complications, high incidence of thrombosis, number of interventions required is very high. And in this one study, that the only study currently published, the average 1 year cost to maintain this catheter was about $6,500 US. So in summary, HeRO device is new and expensive device. The clinical experience is really limited. Can be an option in a highly select group of patients where you have really looked into and confirmed that there are no conventional sites that can be utilized. It requires multiple endovascular interventions to maintain patency, and clearly it's expensive and maybe a last resort option if all other access sites have been really used up. That's where I end my talk. Thank you very much for your attention.